Hand it over to Amy to introduce herself.
Hello.
Hello.
It's nice. I think I saw some of you last time,
Mhm.
I don't know, a couple months ago, right? But so my name's Amy. I'm a nurse practitioner and a wound ostomy continence specialist. I work for a DME company called ABC Medical as their clinical advisor. I also work um, in a separate role, still working with patients in person, folks with ostomies, folks with chronic wounds, um, you know, bowel and bladder concerns. So I still do it both in person and then also as a clinical advisor. I'm here today to talk about ostomies. It's not a really formal thing set up for anybody. I know a lot about I know a lot about ostomies. I've been doing it for a long time. I've worked with folks with spinal cord injury for a long time. I actually started my nursing career working pretty exclusively with folks with SCDI. Um, and in my home, my I live in Colorado. In my area, there's no unfortunately, the hospitals here, pretty small rural area, they do ostomy surgeries, but they have no ostomy nurse or anybody to really help patients after surgery. So I have a with the United Ostomy Association of America, I do kind of a volunteer support thing where I will meet with patients after surgery and kind of teach them how to take care of it and get them all squared away with what they need, so they're not paying out of pocket for stuff that their insurance would cover and that kind of thing. Um, so yeah, that's a little bit about me. I know some of you have ostomies, and I feel like people with ostomies are often the best teachers. I know I've certainly learned a lot from them. But again, I don't really have a formal, I have a slideshow I could show you, but or we could just do kind of a question and answer session, like whatever you guys are most comfortable with.
I'm thinking it's a good idea to do the presentation just because you can talk about like different products and stuff that people might not
Yeah.
know about.
Okay.
Um, and then yeah,
Um,
we have people on that have ostomies, ileostomies, and newly made ostomies too. So we can definitely have a little informal Q&A session afterwards. Yeah.
okay. So I'll just talk kind of briefly. I'll just give you guys a real basic introduction and just kind of talk about some of the product options out there. So yeah, we'll just do that, and feel free to interrupt me anytime and share your experiences or throw in some information or ask me a question or whatever. So let me just share my screen with you just one second.
Also, I know that there are a couple ways to do these. And so if there are certain products that are more appropriate for the ways that they do them, or I don't know if you can speak to the ways that they do certain,
Yeah, I would love. I love helping people find the ideal products. Like nothing makes me happier because I think with so many things, and ostomy is like number one on this list. Having the right products that work for you is 100% going to make or break the situation. And having a product that doesn't work for you is going to make it pretty unpleasant. Um, it really depends. And the thing about ostomy that can be a little overwhelming sometimes is there's like a ton of stuff on the market. There's all these different kinds of bags and barriers and accessories, and they all have their place, but it's not one size fits all. Like this certain thing works really well for this person, but might not work well for you. A lot of it has to do with a couple of things. It has to do with kind of how your abdomen is shaped and how firm or soft it is. What it looks like when you're sitting or whatever position you're spending most of your day in. What is the stoma like? What does it do? Does it stick out or is it retracted? Maybe it does both. Maybe sometimes it's retracted and then sometimes it sticks out. So finding the ideal product has a lot to do with your individual body. And so what helps with that more than anything is having somebody who knows what they're doing take a look at you. An ostomy nurse sometimes, or you can figure it out on your own too, but that can be a little stressful sometimes if you're just, you didn't have any information at all. But really, we want to look at your body. We want to look at your stoma. We want to see where it's laying. What does it do when you're transferring? What does it do when you're sitting in your chair? Is your abdomen kind of flat, or is there a skin fold right there next to the stoma? This is really what's going to determine the best product for you. And then there's also some things that are completely optional. It's like, well, do you like a transparent pouch that you can see in? Is it easier for you to put it on like that, or do you prefer an opaque pouch? One that you don't, you just feel like it looks better that way. There's also some drainage, like how you're going to empty it options, depending on what kind of ostomy you have. We could talk about all that stuff. Um, yeah, let me pull up my PowerPoint.
All of that was already a lot to think
There's a
about.
lot. There's a ostomy is a lot because the thing is, it's just like it's like shoes. I really think it's like shoes because think about there's so many different kinds of shoes on the market, and something that's comfortable to one person might not be for somebody else. So I really think the best thing for anybody who's got a new ostomy, especially, is to meet with somebody who's got some training on how to fit somebody with the ideal product, and then have that person sample you like quite a few different things. Like, okay, try some one pieces. Try if that's an option for you. Try some two pieces. Try some of this brand. Try because there isn't like a superior ostomy brand, in my opinion. Um, Hollister, Convatec, and Coloplast are the three big companies in the U.S., but there's some smaller companies too, like New Hope and Marlin and Symed. So yeah, there's about six total companies. And they all have different, they're all a little different. Like they have different perks and sometimes they have different drawbacks. But I really think the best thing is to get a bunch of samples and just try them out. And most of these companies will give you free samples to try. So that's something that I help people with all day long. I order people free samples of things, but you don't have to go through a medical professional. These companies typically, if you call them, um, you can say, I'd like some samples. It helps if you kind of know what you want. Um, but they'll send you free samples in the mail for you to try.
I have a question from what you
Sure.
just. So, for instance, someone like I don't want to keep pointing you out, but someone who just had a procedure done, a surgery done, right? They usually send you home and they might have a VNS nurse come and see you for a while, tend to your wound or something like that. So when you say have someone knowledgeable come, is the I'm assuming from experience, the doctor is not the person that you mean, and there's not going to be a nurse that's
Oh,
how do I get someone like you to
yeah.
come check me out? Like, how does that work? Does insurance cover that?
It depends. So, ideally, it depends on where you got the surgery. So if you get the surgery in a place, um, and a lot of this has to do with like access, so if you're in a rural area, it might be real difficult to be honest with you. But if you're in a more of a your major metropolis somewhere, your hospital where you got the surgery likely has an ostomy nurse. Now, let me say that sometimes how it works in the hospitals is it's like, well, you meet with this ostomy nurse like twice right after you've had surgery, and you're recovery. After you have surgery, it's a lot. Like you've got drugs on board. You know what I mean? Like there's a lot going on, and so meeting with somebody twice while you're still hooked up to IVs and things, sometimes that's not like I would not expect anybody to retain everything in that situation. And so some places will have the ostomy nurses available to you on an outpatient basis. It just depends on the facility where you can call them, talk to them after you go home and be like, okay, so now I have questions, or this thing you sent me home with isn't working well. And that's not uncommon because most of the time, the hospital, now, sometimes the ostomy nurses will order their patients a bunch of different samples as they leave. So I always did that for my patients. Sometimes they won't. They'll just send you home with whatever they carry in the hospital. That's where it can be kind of dicey because the thing that they carry in the hospital really might not be the best thing for you. Um, but to answer your question in terms of how you get an ostomy nurse, so some of your home health agencies will have ostomy nurses. And so if you're being sent home with home health, you can always say, hey, I'd like to meet with an ostomy nurse. Do you have an ostomy nurse available? And then they can send them to your house. If they don't have that available, then you can try contacting the hospital and their ostomy team there to see if you can come in on an outpatient basis for additional education and support. If none of those things are an option for you or you're not getting anywhere, here's what I recommend. And I'm definitely going to share this link with you is the United Ostomy Association of America is a really cool group. And I'm going to definitely share this with you, but they have a support group locator. You can type in your address, it'll give you all the support groups near you. And the support groups are really great because, well, one, they have folks with ostomies in them that you can talk to them, but usually there's like an ostomy nurse who's behind it. and often you can get in touch with her, and then you have a medical person on board. So that's a great way to find them. And then you can also look on I'll give you this too. So the Wound Ostomy Continence Nursing Society, which I'm a part of, they have an ostomy nurse locator too. So you can look in your region, and people who are ostomy nurses will list themselves on that website, and you could reach out to somebody on there.
Are you sharing your screen? Because I'm not seeing these links. Or are you putting them into the chat?
Nope, I haven't shared them. I'm going to share them. They were just a response to the question I was asked, so I didn't type them out, but
Okay.
I definitely will.
Just
Perhaps
so
send
everyone
them.
knows, so if you are not a part of our mailing list, everything that Amy shares with me, if that means the slides, the links, anything, I'm going to send them on a group email. If you are not someone that receives our group emails, then put your email in the chat so that you can receive everything.
Natalia, what would you like me to do about those two links I just mentioned? Would you like me to share them in the chat now, or do you want me to email them to you?
Both,
Okay.
if that's okay.
Um, yeah, totally. So um, so let me just pull them up really quick, okay?
Okay.
And I know I keep talking about the United Ostomy Association of America, but they're pretty great. Like they have so much patient information. Um, yeah. So okay. So I'm going to send you the link here to the United Ostomy Association of America in the chat. If I can figure it out. Okay. So United. Right here. And I'll send the specific part of their page that gives you the support group finder, um, which is kind of cool. And so I'll send that now. And I'll also send you the where you can look up and find a local wound ostomy continence nurse.
Nice.
Yeah.
Oh, I know if you have my email address or not.
You might as well just give it to me, and if you get duplicates, you get duplicates.
Okay, you ready?
I got you, Sarah.
Okay, so there's that. So I sent those in the chat.
Thank you.
Yeah, and that's useful stuff. And sometimes I really like the support groups because it's usually got like at least a couple of folks who've been doing this for a really long time, and they know everything and everywhere to go, like in your community for stuff. So it's cool. Yeah, so there's that. Any other questions about that stuff?
Everyone's okay managing the chat? Everyone here's on here is okay? If
Yeah.
not,
You had mentioned also the website for the ostomy nurses.
Yeah, I put it on the chat.
I only see two.
I don't know why it went. Oh, it went to direct message. I'm so sorry. So for some reason, it went as a direct message to somebody. So I apologize. Let me resend.
That's okay.
So I must have clicked somebody's name or something. So yep, here's a way you can. Here you go.
There it is.
there we go. Okay, got it.
Yeah. And yeah, what you said about doctors generally not. So most medical, and I don't mean to be cynical, but I will tell you that my decade of experience, generally most people in healthcare, like your primary care doctors and your typical RNs and things like that, they have really limited knowledge on ostomy. It's just not a big part of their training. And so, your doctors may understand what it is, and your surgeons are excellent at making one, but they don't really understand the fitting process or the product process. So sometimes they do. But generally speaking, your best bet is going to be reaching out to either, folks who deal with folks with ostomies a lot, like ostomy nurses, or individuals that have ostomies themselves, in my experience.
Cool.
So let's see, I could probably share my screen.
Do
I
you
don't
have
think it won't let me share my screen. It says disabled.
that work?
We're trying. Yes.
Yes.
Um, can you guys see it? And you can just ignore the AB. I work for a company called ABC Medical, and this is the training that I use to teach people about ostomies in the company, but that stuff, don't even worry about that. Let's see. Yeah, so I mean, this is just kind of generally speaking, and this is a very beautiful stoma on like a perfect abdomen. Most of us, myself included, do not look like this. But an ostomy it's just a surgically created opening that allows urine or stool to leave the body. It's not, there's really three types of ostomies that we're going to be talking about. But generally speaking, if you're looking into an ostomy as an alternative to a bowel program, it's typically going to be a colostomy or sometimes an ileostomy, depending on what else is going on. There's a third type of stoma called a urostomy, which is strictly dealing with urine. These are most typically found. These are for people that have bladder cancer, or sometimes there's other reasons. But generally speaking, for today's chat, we're really talking about colostomy or ileostomy. I'm happy to talk about urostomy too, but for the most part, people with urostomies, again, there's other reasons that they're made, but generally speaking, it's folks who've had bladder cancer and they've had to remove the entire bladder. So colostomy and ileostomy, talk about the difference. So just terminology, terminology is kind of important, I think, when we're all on the same page. An ostomy it just means an opening. An ostomy is just an opening on the body. The stoma, when we talk about having a stoma, this little part right here is what the surgeon has made, and it's made out of a piece of your own intestine. So basically what they've done is they've rerouted things. So if you've had your intestines here, they've, at this point right here, they've severed the intestine here where it meets the rectum, and they've brought up that end to your abdomen, made a little slit, and sutured it into place. And it sounds like this really crazy surgery, but it's actually pretty straightforward and easily reversed when it's just, when it's that type of colostomy formation. A lot of folks that have, here's why it's so reversible. So a lot of folks that have had diverticulitis or tumors of the GI tract, or even traumatic injuries, gunshot wounds to the abdomen, you see it all the time. They do temporary colostomies all the time. What they'll do is, because something has happened here, whether it's a tumor or a bullet, to compromise the intestine, well, stool still has to go through it. If there's a hole in there, the stool is going to leak out of the abdominal cavity, right? So they'll give the person a diverting colostomy for 3 to 6 months while they heal, and then reverse it. And the reversal is usually pretty straightforward. So reversal is definitely a thing, and a possibility. Ileostomy, which is also reversible in some situations. Ileostomy is differing from a colostomy because what we're dealing with here is just the small intestine at this point. Where the small intestine meets the large intestine, this guy, that's the point of diversion. And so for some folks, like for example, if you have ulcerative colitis, they may take out the entire colon, and then you have an ileostomy. And in that situation, it may not be reversible because they've taken out the whole thing. But if you just had colon cancer and they needed to take out the tumor surgically and treat you with chemo and radiation for a few months, an ileostomy could be temporary in that situation. They would just wait till everything was healed up and then reconnect you. The main difference between these two is, well, first of all, where it's at on the intestinal tract, right? But the output is different. So with your colostomy, the output is usually a little bit less frequent and a little bit thicker. With an ileostomy, the output is often a little bit more frequent and a little bit more watery, so liquidy. And that's just because of where it's placed on the intestinal tract. With a colostomy, there's not much, once things kind of settle in, things aren't that different. Your dietary and fluid intake is not really unchanged. There's not really any dietary restrictions. It's just kind of the exits moved. With an ileostomy, it can be a little bit more tricky. just because, you know, your colon, this big guy here, is what drinks for you in your body. When you're drinking liquids, your colon is really what, and it absorbs the liquid. And so your other, this part of the intestine can do it too, but it has to learn how. And it doesn't always do it 100% as well as the colon would. So when you have an ileostomy, especially initially after surgery, it's more likely for you to experience dehydration for sure, because you have this high liquid out and your small intestine hasn't quite picked up the slack yet. And people with ileostomies do experience higher rates of dehydration just because their output's liquid and the body just doesn't have time to absorb quite as much water as it would if the colon was still there. So they have to be mindful about not getting dehydrated. Also, because the intestinal tract is so short here, you know, some medications, like especially extended release medications, they may not be appropriate anymore because they may not really dissolve in time. Like they'll come right out of the coma. So they may need to, you know, it's good generally to kind of go over your medications with your pharmacist. Say, hey, I have an ileostomy. This means I only have a small intestine. Are these medications actually going to break down and be absorbed in time? And then sometimes people with ileostomies may, I don't want to say dietary restrictions, but they may find that certain foods can cause blockages. A lot of this can be avoided by like really chewing things up, but sometimes it can't be. Things that aren't digestible. You know, think about like the strings and celery and stuff, like things that aren't digestible sometimes can cause blockages because this part just doesn't have the ability to really break it down, as you know, which would happen if you had your whole intestinal tract in there. So that, you know, that's just one of the differences, but they're both I mean, they're not uncommon, either one, and they're both reversible depending on what's going on. And there are some product differences. But yeah, and again, I'm not going to talk too much about urostomy. I definitely can. If somebody here is got a urostomy or wants to know more about that, tell me now, and then I'll include that. But generally speaking, this is something that's not, you know, again, it's typically for bladder cancer. So yeah, oops, my computer froze. Do you guys have any questions about anything so far?
I do. So it sounds like if you were going for this as an elective procedure,
Yeah.
that they'd most probably opt for the colostomy, not the ileostomy.
Generally speaking, yes.
Okay.
Almost everybody that I personally have known that had an SCI and decided to go that route, where instead of having a bowel program, they'd prefer to have a colostomy, or sorry, an ostomy. It's been a colostomy. It's been a colostomy. It's just kind of it's the procedure of choice that's typically what you see there. But again, you know, it's not that an ileostomy would be wrong. There just might be other reasons why somebody else might have that. It's a lot of places, and this is something you can always check, you know, like, so, you know, if you're thinking about getting this done, you can shop around. It sounds terrible, but you really can, because it's an elective procedure. It's just like getting plastic surgery or something, like, you know what I mean? People look around. And so if you are thinking about getting, if you're thinking about getting a diverting colostomy as an alternative to a bowel program, you absolutely should shop around. And what I mean by that is talk to other folks who've had this done. I'm going to say it, I don't want to be, you know, too negative, but not all surgeons are great at making stomas. They're just not. And so what you want is someone who does a lot of these. It's not like it's this high risk surgery. It's just that here's the deal is you want a stoma that's been placed in a good location. So here's a question you can ask your surgeon is like site marking. I think it is so valuable, and I want to tell you guys what it is. And I've site marked a bunch of patients, and they always turn out better. Site marking is meeting with an ostomy nurse before you even go to surgery, and they pick out the location with you of where you want the stoma to be. Because everybody looks the same laying flat on their back in the OR. You know, they don't know how your belly looks when you're sitting in your wheelchair, or where you wear your pants or anything like that, right? And so site marking is something that ostomy nurses can provide you with. And basically, we just hang out with you and make you move around and do different stuff. And we talk about where you can see it, because that's another big one. What if they stick it real low where it's hard to see? You know, so site marking makes better outcomes. So as a way to advocate for yourself, if you're planning an elective ostomy, request site marking. And you're really, I don't know how to say this, but your really cool surgeons are 100% on board with it. They're like, yes, please do that. The ones that give you resistance to that, I would say that's a red flag, because even their own medical society, like the Association of Colorectal Surgeons, has put out a consensus statement saying we should all have our patients site marked first. It has better patient outcomes. They're happier with the stoma. It's just better. It gives you some control over the situation too. Like, I would prefer it here if possible. Okay, you know what I mean? So, and it can be a really helpful thing to do. So definitely recommend site marking, because, you know, it's just, we want, the ideal stoma location is on a flat surface. We don't want to put it in like a crease, you know, if you have a big crease in your abdomen, we don't want to put it in there, because it's going to be harder for that ostomy appliance to get a good seal. The best seal is going to be in a place that's nice and flat. We want a place that you could easily visualize so you can take care of it. So not real low where it's like tucked under the roll. And then we also, you know, it's good to shop around. You know, you want to get somebody who makes nice stomas. They make nice, you know, round protruding stomas that are easy to work with. And again, because it's an elective procedure, you can definitely talk to other people and get some recommendations. And talk.
Speaking of these round protruding stomas, right? So I just recently saw a colorectal surgeon, and when she explained the way that she would do the procedure is not that she would like kind of cut it and then attach it to the wall, the abdominal wall, but that she makes a slit in it, and then that opening is what gets attached to the abdominal wall. And then if I decide to reverse it, they just close that slit back up and unstick it from my abdominal wall. But I'd never heard that before.
Yeah, I mean, that would be kind of, I think what they call that is like
is that like a loop?
Yeah, because
that's what I had.
Bringing it up. Does your stoma protrude a little bit?
A little, but I'm more like an oval and a little bit flatter. So yeah, I'm not like a full round coming out, because I was not fully slit.
Yeah.
Like cut.
Right. And that, you know, that's okay too. You just don't want it where it's like concave. You know what I mean? And sometimes that happens. Sometimes that happens despite everybody's best intention. For example, if you have a pretty big belly, they only have a certain amount of intestine to work with. So they may not have enough to really make it kind of stick out. And there's other things that can happen too. I would say that having it protrude is helpful, and they can do it, you know, as long as it's protruding a little bit. It gets Yeah. And so, and she will, and Natalia, what you're talking about, and you can always ask her, hey, can we make sure it protrudes a little bit? It's called maturing the stoma, is what they call it. The surgical technique is called maturing the stoma, where, you know, when they make that slit, they're kind of folding. And I'm not a surgeon, so I'm not good at, I'm not sure exactly what they do, but they fold it and they kind of, then they suture it. So you have sort of like a little rosebud, if that makes sense. You know, so it's not like sucked in. I think it's important to have it stick out a little bit. I think it makes things a little bit easier, and you can understand why, because, you know, and again, it's not always possible. Sometimes it doesn't happen, and there's ways we can deal with that. But
can I show you mine and you tell me exactly what I have?
Yeah. Like if it's sticking out or not?
No, mine is like really cute. I guess it's the best way I can explain.
Do you have an ileostomy?
Nostomy, colostomy, regular
colostomy. Yeah, I mean, does it? You can show it. I see them all the time.
I'm spotlighting you.
I don't care to show it. No one, everyone's okay.
I think it's great.
Can you stop sharing your screen, Amy? Because it's just a black screen right now. So as I want to spotlight Lily, it's there we go. There we go. Show and tell. Show and tell.
Yeah, that's perfect.
Oh, that's super cute.
So see how it sticks out a little bit? I guess like sometimes what will happen is it's like a hole, and that's not a hole. That's sticking out. You have a little protrusion there, and see how it goes right through the hole? That's why having it protrude a little bit is helpful, because when you think about it, when you're laying down an ostomy barrier, the part that's sticky to your skin, you know, have that hole, you want the stoma to protrude a little bit through that hole, so whatever comes out of that stoma kind of spouts into the bag. And so that's why it's helpful.
That's a very nice looking. That's a very nice looking. Yeah, that looks nice. I feel
Very
the one I don't know, the ones I see in pictures are scary a little bit, but that looks nice. So the way that you have it right now, Lily, you don't have the bag attached to it. You just have it kind of covered.
There's a wafer, and that I make I cut up like a little hole that like fits my stoma, and then I peel off the little sticky barrier and it just sticks onto my skin, and then the bag itself, it's like, like Tupperware, like you just like attach it on, and it's like, and you do like little clicks all around, and then that's
But
it.
you don't keep it on all the time, the bag?
Do I what?
You don't keep the bag attached all the time?
Bag is attached all the time.
The bag was attached right there?
It's a two-piece. Yeah.
Let me show you a picture. I can show you a picture of exactly what she has. I think it'll make a lot of sense. Let me share my screen.
Okay,
and I'll show you what I mean. Let me see if I can do
I
it.
didn't see a bag. All I saw was like tape over it.
She had a bag.
Yeah.
The end of it, because it was like tucked down.
Huh, okay.
Here, let me see if I can share this with you. And you're wearing a one piece, right?
Two-piece.
Two
There's
piece.
it's a wafer and then the bag.
Yeah. So there's
It's from Coloplast. It's what you mentioned earlier. That's the brand I use.
yeah, Coloplast is great. So is that all the Coloplast, Convatec, and Hollister, they all make great products. It's just some people, just a lot of it has to do with preference. But here, I'll show you what okay, here's a good picture. Can you see this?
No.
Oh no, I didn't share it. Did I not share it? Shoot. I thought I did. How's that?
Nope. Let me see. And you have access from what I see. There you go.
I'm just bad at computer.
Okay.
Okay, there we go. So yeah,
No, I'm 2 weeks today.
nice.
Oh, sorry.
Yeah.
I forgot I wasn't muted.
Oh, hey, congratulations.
Congratulations. Yeah, that's what I was thinking. Yeah.
But yeah, so this is like the so here.
That's the one that you're highlighting right there. Yes. That's what I do.
Two-piece. Yep. So this part sticks to your body. The hole you cut, or you can get pre-cut, if you don't want to cut the hole, they'll pre-cut it to different sizes. But so you cut the hole so the stoma can stick through it, and then you apply this to your body. This is really sticky, strong adhesive on it. And then you snap this bag to it. And what it looks like is, so this guy's got a stoma, and he's, this is a different Coloplast product, but he's using a two-piece system. He's snapping a bag to this. This sticks to his body. Typically, you don't need to change this wafer or this barrier, every 3 to 5 days is what most folks are doing. You don't have to, if you get one that fits you and it adheres really well to you, that stays in place. Now this bag, you can empty it as needed, but there's also an alternative for folks that, let me show you this video. There is an alternative for people with colostomies, in particular, where you can not empty the bag, you can just pop it off and throw it away. And so let me show you this. Let me see if you can you guys see the video? Oh, no.
Yes.
So he's using a two-piece closed system. This is a Coloplast product, but everybody makes it. So I think it's nice. You don't have to worry about emptying. If you have a lot of output, this won't work. You go through them too quickly. But so here's the barrier. And you can check it out. This is like a great video that I showed you. So he's cutting the hole the size of his ostomy. And you'll notice that this barrier is not totally and problems that experience leakage. If your belly's soft, or your stoma is kind of down in a dip, you need a convex barrier as opposed to a flat barrier. And that's what he's got. So yeah, he's cleaning his skin off. There's a stoma. Yeah, see how it's not totally flat on the back? And you can see why too. I mean, this sounds like a weird little nitpicky thing. Real, see how his stoma is down in the dip? It's not on a flat surface. And so having this convex system goes down in that dip and gets him like a really good seal. And this is where an ostomy specialist can help you out by figuring out specifically what kind of barrier will best fit your body. So that's the wafer, the barrier that just stays there. And he'll probably change that twice a week. But now he's got a bag that he can attach to it. And then, like she said, it clicks into place like Tupperware. They also make versions where it actually has an adhesive coupling too, if this is too hard to deal with. It snaps on there. They don't all have this locking ring. This is just a Coloplast thing, but it's nice. So it's on there. So now when he has a bowel movement into that bag, it's a closed pouch. You can just take off that bag, throw it away, and pop on a clean. The alternative to this is using a drainable pouch, where instead of taking the whole thing off, you just empty it from the bottom into the toilet. So now he's taking the whole thing off. But yeah, that's a closed pouch. I guess that the main thing is typically insurance will buy you 20 bags and it depends, commercial insurance and Medicaid's could be different, but Medicare, for example, and a lot of commercial insurances and many of the Medicaids will purchase you 20 barriers and 20 bags a month if you're using drainable systems. And a drainable system looks like this. It's the kind you empty from the bottom. If you're using a closed pouch, they'll buy you 20 of the barriers, the part that sticks to you, and 60 of those closed bags as disposable bags a month. So you have enough to change it every day. But I guess an important consideration is how much output do you have? So if you have a lot of output, you may go through those closed pouches too quickly, and your insurance may not cover more. Drainables, that you can always drain it throughout the day. So it's something it's worth trying, and then they also have closed one pieces too, which can be a nice option. So if you're someone who has a bowel movement like every other day or something like that, even with your colostomy, you don't have a lot of output, a one-piece closed system is definitely an option. It has a lighter adhesive on it. You have your movement into it, and then you take it away and you throw it away and you pop on a new one. But again, they only give you 60 a month. So, if you're going through more than that, might not be the choice for you. You might do better with a drainable. Yeah, I don't know if you guys have any questions about that. One pieces are an option too. So we just talked about two pieces, right? One piece is an option too. It's where it's where the barrier, the part that sticks to your body, and the bag are all one unit. So there's nothing that snaps together. Some of this is patient preference. So like if you have a two-piece, you have the option to change the bag out a little more often than the barrier, which can be beneficial. Like sometimes it might get dirty and you would like to change it without having to change like the whole apparatus because this part's still okay. Another option is they have these little mini bags, like itty bitty mini bags. And so those can be great for things like intimacy and going swimming and stuff like that. So, but you can't wear it forever because it doesn't have a lot of capacity. So if you have a two-piece system, you can switch between having a full capacity size bag and then switching to a smaller mini bag for certain activities as needed. So it gives you some versatility there. You can also angle it in different directions. So this guy could go straight down when you're up in the chair, or if you're in your bed at night, you can re-angle it so it's off to the side and easier to empty that way. If you wanted to, you don't have to. It just has some options. With your one piece, once it's stuck on there, it's kind of in that position. But some of the benefits to a one piece are that it's like a little bit flatter, a little bit lower profile, which is important to some people. Also, there's some situations, for example, if you have like and this is something we would hope wouldn't happen because you get site marked first, but let's say your ostomy ends up in a really deep skin fold. Like you've got a bigger abdomen and there's a fold in it, and man, they put that stoma right in the bottom of that valley. It's going to be really hard to get a good seal with a two-piece because it's stiffer and it's not going to bend down into that skin fold. So we might have to use a one piece to try to get a good seal there. Or if you develop like it just depends. It depends. It has to do with your abdomen. But some people do much better with a two-piece because they actually benefit from that stiffness. They'll find that the stiffness of that two-piece, like especially if you have a little bit of flab on your abdomen, can really like flatten everything out and get you a good seal. So that's why I kind of like people to try both. Unless I just think like when I'm working with patients, I'm like, okay, there's no way this one's gonna work. Yeah, let's cross that off the list. But a lot of times, let's try both. Let's see one like my definition of of an ostomy product that works for somebody is one that lasts at least 3 days with zero leakage, that is gentle on your skin. When you look at your skin, it doesn't look like you're having any kind of allergic reaction to the adhesive, and that doesn't surprise you. Like you're changing it on that 3rd day because you want to, not because it's starting to come off. So I want something that's reliable, that lasts at least 3 days and doesn't hurt your skin. And that tells me that, okay, this is a pretty good product for you.
I have a question, Amy.
Sure.
Is there no world where you can have where you don't have, how do I say this? Like you can kind of plan your bowel movement so you don't have to have the bag there attached all the time, just taking things. Like if there's something that you can keep it covered, and then like you get home and then you can put the bag on and then like squeeze and let everything come out, and then keep a bag on like at night just in case that's going to happen. But is there a world where people do that
Yes.
and not just have to be constantly leaking it?
There is. And so here's the thing: is it's. I mean, you guys are probably familiar with bowel programs. You do the same thing at a certain time, and you kind of get the bowel to do its thing when you do the thing, right? You can do the same thing, but only with a colostomy. So with an ileostomy, you can't do it. But if you have a colostomy, and it's not very common in this country, and I don't know why that is, but oh my God, the United Ostomy Association of America has like a whole crew of people with ostomies that are all about it, and they publish all this information about it, and they'll teach you all about it. But basically what it is it's called colostomy irrigation. And I have some patients that do it successfully. It just requires, like, you have to be dedicated. But essentially you're giving yourself an enema through the stoma every morning. And then you wear, let me show you this thing. And it works, you run a whole big bag of fluid in through the stoma, and you kind of let it sit there for a minute, and then you let it all come out, and it rinses all of your bowel out. So you have to have an hour to dedicate. You got to have time every morning to do it. Some people do it every morning. Some people will do it every other morning. But then you sort of flush everything out. And there's, a little something might come out, but not much. And so then in those situations, you can wear what's known as a stoma pouch, or a stoma cap instead. And I can show you. So basically, let me show you this. So look at stoma irrigation sleeve on a person. Let's see if there's okay. There's great videos on it. So yeah, here's gosh, I wish I had a picture of like a real person. But there's all these great folks on YouTube who are like, here's how I irrigate my colostomy. And they do it, like they show you the whole thing, which I think is super helpful. But okay, so this is like this is not a real person. But basically what you do is instead of getting regular size bags, you get what's known as a stoma irrigation kit. And it comes with a bag, and it comes with the little cone. There's like a little cone on the end of the tubing that you put some lubricant on and kind of stick it in the stoma. And then you run that bag of water into it. And then you use this special, really long, because it'll reach to the toilet. It's this really long bag, and you just stick it on there while the water is coming out. And so everything inside of you is washing out through this into the toilet. I'll send you guys a link of a real person doing it, because I have a YouTube video that I'm thinking of, and you can watch it. But basically, it's like doing a bowel program through the stoma. And it's an option. It's only for colostomies, but yep, if you do it every morning and you flush that bowel out every morning, and a lot of folks do it every other morning, everything in you comes out, so then there's nothing to come out in the bag, so you can just wear a little patch over it.
Yeah, I don't know why that colorectal surgeon said that it wasn't an option when I asked.
Sometimes with a loop. So I've had folks with a loop. You can do it with a loop, but I've had folks with a loop because it's a loop and it's pulled up. Is that with the loop, some of the water will flush out through your rectum as well, because it's that pathway is still open to that water. Does that make sense?
Yeah.
And that doesn't necessarily, I mean, you can still, I mean, I'm pretty sure you can, I mean, it works better if you have the Hartman pouch, which I mean essentially means it's like you're disconnected there. The two pieces are disconnected, and so you're just gonna flush all that out. But I know people can people still do it with the loop, but they may not always like doing it as much because again the water problem coming out the rectum, right? So that's that's probably what she's concerned about, because you probably don't want that. It's not that it's necessary, it's not like unsafe, it's just maybe a little more messy and ineffective. But if colostomy irrigation and use of a patch, like a little stoma cover, versus having an actual bag is a priority to you, then you could maybe discuss having a different kind of surgery that would be more compatible with that. And that would be the kind where they, it's the Hartman's pouch. They probably call it other things too. I can show you what it looks like. It's also reversible, but maybe a little more complicated to reverse. It looks like, yeah, it looks like this. So this is basically the rectum. They cut it. They cut things in half here, and they suture up this end, and it's inside of you. And then they bring the stoma out here. So you still have the pieces that can be connected back together, but you're severed here. But this would work better for colostomy irrigation, because you would irrigate, all the water would be going in here and everything would be flushed out here. If you have the loop colostomy, you can see why. Like, look, loop colostomy. If you have the loop colostomy, yeah, where it's going to be more like this, you can see that if you flushed water in here, probably some of it's going to go this way as well as that way. So, but yeah, I mean, these are all things, like, I think thinking about what you want and what you would like to do to manage it is completely irrelevant. Like, it's very important. And then talking to your surgeon about what you're, like, if your goal is colostomy irrigation, then you should have a surgery where that's super compatible, and that can be done. It's not like the Hartman's pouch is a rare procedure either. It's just another way of making a colostomy.
Okay, Imani has a question.
Sure.
Go on, Imani.
Hi.
Hi.
How are you? Sorry. Hi, everyone. I have a question. My neurologist, right? Because my friend she had a stoma put in. That she had surgery and everything. Yeah, that. And it was leaking, and I asked my neurologist, is it gonna leak if I do it, if I get the surgery? And she said, yeah, sometimes it does leak. My thing is this: if it's leaking, I'm not doing it. I don't want no mess. I don't want any drips. I want it to be dry and prevent sores and stuff like that. That's all I'm saying. Okay.
Absolutely. Who wants that to leak? And so by leakage, what they usually mean is that the product that they're using, the bag and the barrier, what leakage always is, is this. Let me show you. So, this guy right here needs to sit very flush and fit very well against the skin. If it doesn't, if there's any kind of gaps, or just it's not the right barrier for your body type. Like, for example, if you are using a flat barrier and you would be better off with convex, what will happen is the output from the stoma will leak. It'll get underneath the barrier and make it come off. And that's leakage. Is it avoidable? I mean, I would say I have had patients that never had a single ostomy leak. because they had a great stoma, they had a nice, easy abdomen, they got the right products right away, and they're good to go. But most people, during especially the initial phase, like when you're first learning how to put it on, when you're first figuring out what products will work for you, I think a leak or two is expected. What isn't normal is like, I have an ostomy that continually leaks. I never know when it's going to come off. That's when we're like, you know what? You need to come back in. Let's figure out what's going on here. Do you know how to use the products correctly? Usually people do. Okay, but once in a while they've been told something off the wall by somebody and they're doing it wrong, and that's why it's not working. But usually it's just that they need a different barrier. And that's it. That's why having a relationship with somebody who knows these products and can get you samples to try is so important. Because for example, look at them all. There's so many different kinds. There's flat ones, there's one piece, there's two piece, there's convex. And the convex is like, well, there's deep convex, there's shallow convex, there's soft convex, there's concave. These like if you had a lump there, like a hernia or something, you might need concave so it can grip it, you know? And so that's where it gets a little confusing, and it can be nice to have some help, because having it leak isn't normal. Now, in the beginning, when we're trying things out, okay, let's be open-minded, be like, it might leak once or twice, as I'm sure, okay, so that I know that this pouch isn't for me because it leaked. Cross that one off the list, you know what I mean? But like with you know, once you've had it for a couple of months and we've figured out a product that works for you, we shouldn't be dealing with leakage. One-offs can happen, you know, something can happen, but it shouldn't be. Leaking is unacceptable is the way I look at it. If you have an ostomy and you're dealing with continual leakage, something's wrong. You need different products. You need different products. And unless it's a really wild situation, I would say 95, 98, 99 even percent of the time we can fix that leakage with the right products. For sure. So yeah, but yeah, I mean that's a valid, I completely understand why that would be a concern. And there's a lot of accessories too. So I don't know if you guys are using this stuff, but these are really cool. So like if you have, you know, that the weak point of an ostomy is going to be like right where that stoma pokes out of that hole, because that's where stuff wants to creep underneath. These rings could be great for that. And so what these are they're like gaskets. And so this is covered by insurance. They're called ostomy rings or barrier rings or protective seals, depending on who makes them. But they look like this in the package. They sort of feel like silly putty, and you just stick them easier for you. And then you wear the product and it really can help. It can help protect that skin and get a better seal. And there's other stuff too. You know, there's adhesive remover wipes. These help you clean the skin after you take off your old product. Skin barrier wipes, this protects the skin. So after you clean, you know, we want you to clean your skin with plain water, usually pat it dry. You could use the adhesive remover too to get any gunk off. You know, adhesives leave a little bit of gunk. Get that off. So you've got clean, dry skin. You can wipe it with a little bit of this barrier wipe. It's a clear liquid and it kind of protects the skin from the adhesives and from moisture. And then you know, most folks with colostomies, I get them squared away with these rings, almost everybody, because it just really helps. You know, they're not, if you don't have to use them. You can certainly go without them, but I think it protects that skin that's right around the stoma from moisture, and I think it gets a better seal. So those rings can be helpful. And then there's other stuff too. These are nice. I like these. These are called barrier extenders, and so they're also usually covered by insurance. They're like, sort of feel like a hydrocolloid dressing, but it's basically these little strips that you put around the edges, just for an extra sense of security to keep everything smooth. And then if you're doing stuff like swimming or sweating out in the heat, you know, edges of adhesive of band-aids and things kind of roll up when they're wet. This will prevent that from happening. It keeps everything nice and flat. So yeah, and I can definitely give you guys, oh, I should give you this too. So any of you guys with ostomies that want to learn more about what other products are on the market, let me share this with you. This is like how to get in touch with Hollister, Coloplast, and Convatec directly and say, hey, send me a catalog, tell me what you got. Or hey, I'm interested in learning more about your look in the catalog and say, hey, I want a sample of this. They'll send it to you. So let me share that with you. If I can. I don't know what I'm doing. I'm so sorry. I'm so bad at Zoom. I always use Teams, so I'm really not great at oh, here we go. Okay, let me stop my share. And I'll send this in the chat. So yeah. And just for fun, I'm gonna send New Hope and SciMed too. New Hope makes some cool products. They make some really specialty products for folks with ostomies, like things you wouldn't necessarily think of. And so that they're worth a look too, I think. So I'll send you their information as well.
Do we have any questions so far right now? Yes, Marion.
I do. I have the urostomy and an ileostomy.
Okay. Sorry, I didn't mean to you. I didn't mean to dismiss you.
And sometimes the ileostomy, the poop gets caught up in the top and it comes off.
Okay.
And the skin in the process, the getting the poop on the skin causes the skin to redden. And sometimes to get as bad as to bleed right around the stoma. Are there products? I've been using barrier wipes, sometimes an antifungal around that to try and clear that up. But do you have any suggestions for what would help reduce that reddened area outside of the pouch as well as possibly inside?
Yeah, so I mean, are you comfortable if I ask you a couple of questions?
Of course.
Okay, so with your ileostomies, one thing about ileostomies, and I'm sure you might know this, but ileostomies have an output that's very corrosive to the skin, because it has digestive enzymes in it that are used to break down protein in your food, but your skin's full of protein too. So that output is really caustic to the skin. What are you using, a 1-piece or a 2-piece?
I'm using a 2-piece.
Is it flat or convex?
Convex.
Have you ever used a barrier ring?
I use a barrier ring.
You use a barrier ring. And so even with the convexity in the barrier ring, you're having problems, just to make sure I'm understanding, you're having problems with the output kind of creeping underneath the barrier and sitting there and hurting the skin?
Sure.
Okay. What products are you using, if you don't mind me asking?
Coloplast right now.
Coloplast, okay.
Oh, actually, no. We quit using Coloplast because it looked like my skin was allergic and I ended up being hospitalized for 5 days because the skin broke down so severely. So now I'm using the red and white. I just lost it.
Okay, Hollister.
Yes.
Hollister.
The Hollister products.
Okay, and you're using a 2-piece convex from Hollister. Now, is it extended wear? Do you know?
I don't know whether where it says extended wear.
If you have the product number, I could check. I don't know if we want to do all that.
I don't have it sitting right in front of me.
Okay. So that's a thing to look at. So Hollister makes 2 levels of adhesive. They make extended wear, which is known as their flex wear, or their Sarah Plus, and then they make one that's FlexStend. FlexStend or Sarah Plus is their extended wear, and Flex Wear is their lighter adhesive. Anybody with an ileostomy, because that output is so corrosive, probably should be using FlexStend or Sarah Plus because it's just a stronger adhesive that holds up to it better. How often is that happening? Is it every time you change it, it's getting underneath there?
No, but sometimes then I have accidents because it loosens up the seal and I have everywhere.
Well, my thought is that, I mean, I could send you some samples to try to see if they work any better for you. I find, like, for liquid output, for ileostomy output, I like Coloplast protective seals. Have you ever used those?
I don't think so. No, that doesn't sound familiar.
They hold up, so they're a little, it's a barrier ring, you know, so Hollister has a barrier ring that's kind of a brown color. Coloplast has, they have one like that, but then they also have one that's called the protective seal, and it's white colored, and it tends to not hold the moisture in from the output, and it holds up better, in my experience, a little bit better to ileostomy output. You know what I could do is, if you'd like, I could send you some samples, if you're comfortable with it. If you want to just, I don't know,
Absolutely.
if you want to, do you know how to message me your phone number? Because I could just call you,
Sure.
and I could get all that information, and we could continue this conversation if you want.
Excellent.
Yeah, I'll just send you some samples. Also, yeah. Anyway, we'll talk more. There might be some other convex options that might work better for you, just depending on what's going on. But I have to ask you lots of questions about your stoma and your abdomen, so we could do that on the phone, I guess.
Excellent. Thank you.
Yeah, no problem.
So Marion, will you put your information in the chat for Amy, or do you want to?
I already did.
I think I got it. Yeah, right here.
I direct messaged her. Thank you.
Yeah,
Okay.
I'll just number, and I will call you. Is later today okay?
Sure.
Okay, cool. I'll give you a call.
Thank you.
Absolutely.
Sarah, not to put you on the spot, but I know you recently had an ileostomy. I don't know if you have any questions or insight to give about it, if you'd like.
I was just sending my number to Amy. I'll do that later. Yeah, so I was injured in 2008, so I've been dealing with the bowel routine for almost 15 years. A year ago, I was just desperate. My bowel just seemed to be not functioning anymore, really. And I tried to get my local doctors to help me get a Peristeen device, which is like a do-it-yourself colonic, at-home colonic. And one delay after another, many of them didn't even know what it was or didn't want to deal with it. Finally, I had some testing done, and they found that my colon had some problem. And long story short, they said I had to get an ostomy. And when I went in to speak with the surgeon, I may be skipping a couple of steps, but he said, as you age, Sarah, your colon is just gonna stop functioning worse and worse. So what I recommend is taking out your colon and putting in an ileostomy. And this too will make it so you never have the risk of colon cancer. And also, thank goodness, I never have to go through the process of a colonoscopy again, which was always a nightmare for me. But so I got the ileostomy in late June, and he told me that when they took out the colon, it was twisted in two places, and somehow, without knowing it, doing my bowel routine, I had perforated my rectum, and there was a huge abscess, a huge infection. So it was good to be rid of all that. Since then, it's been a learning curve. I've really I've had a few accidents. Luckily, they've been at home. I'm terrified to go out, actually. I was invited to Thanksgiving dinner, and I just said, no, I'm not secure enough to go to someone's house and stink up their bathroom. And well, I didn't tell the hostess this, but and eat and drink all for hours and hours and be away from my own bathroom. That's what I told her. So I still have to get more secure with it, but and I tried a whole bunch of different products, and I've settled on a Hollister 2-piece. But I think that as I've gained a little weight from this, I was on a liquid diet prior to the surgery for like 2 months. So I was very thin when they did the ileostomy. And now, of course, that I can eat again, I've gained a little weight. And I think maybe I need a convex barrier, I just don't know. So I would love to talk with you too, Amy.
I would just try it. If you've gained a little bit of weight and your abdomen is a little bit fluffier, now, that's often it. You know, if you're having stuff creep under the barrier, convexity, where do you get your supplies from?
Oh, well, I still have visiting nurses coming because I developed wounds following the surgery. I'm not sure how one of the wounds occurred, but probably from a really bad mattress and inpatient rehab. And the
Gotcha.
other wound was associated with the incision. So they've just been getting this stuff for me.
And they can get you a convex product. So what we could do is I can call you and I can give you product numbers for
Okay.
basically what you're using now, but the convex version, and you can request the Home Health Agency to order those for you instead.
Okay, thanks.
So, yeah, and the help too. Yeah, I'll just give you the product numbers, and I can also yeah, they should be able to order that stuff for you.
Yeah, okay. But yeah, I mean, I would love to have a more reliable time of day when I knew I was going to have a bowel movement, but with the ileostomy, it's just a constant thing, and there's no knowing whether it's going to be a day when I have to go to the bathroom 3 times in 5 hours or once in 5 hours. It's random. And yeah, so it's a real learning curve. But it's so much better not to be in torture and going through bowel routine for 2 hours every day with no good results and taking a ton of laxatives and then having the accidents at night. Oh my God, I'm so glad to be done with that.
Mm-hmm.
Yeah, if you want to send me your phone number, I can call you, and then I could get your I could send you some samples of those Hollister products to try if you wanted.
Okay, that would be great.
Yeah, just if you can, just send me your number and I'll reach out to
Okay.
you.
So you're putting that in the chat, right, Sarah?
I will, yeah. I was
Okay.
just waiting to see if somebody had a question for me.
Okay. Does anyone have questions for Sarah?
Why an ileostomy over a colostomy again?
They found, let's see why did he say, oh, this guy said that he said with spinal cord injured patients, the bowel and the bladder, he said, just gradually stop being able to function over time. So he recommended the ileostomy because I'm a spinal cord injured patient. And you know, I didn't go for second and third opinions. Maybe I should have. But given the condition of my colon, I think he made the right decision. Yeah. But for younger,
yeah, go on, sorry.
For younger patients, I think the colostomy sounds really good. And, you know, God knows they can always go back and take out the colon if they have to, but you might as well go with the simplest procedure first, as long as the doctor thinks it's good.
Sarah, before having the procedure, how long before then had you had a colonoscopy? I asked because you said you had twists going on, perforations going on. Is it because you not had a colonoscopy in a long while, or did they not see that?
Well, every time I had it, let's see, I forgot when the last one was. I think maybe 2013 or something. And at that time I said, okay, doctors, I'm never, ever going through that again, because I had 3 or 4 colonoscopies since my injury, and I could never get cleaned out adequately. And then all those strong laxatives would make me have horrible accidents for like 2 days afterwards, at least. So I said, never again. I don't know if it was due to the twisting. I have no idea when the colon got twisted. No clue. Yeah.
Sharon, my dear, you're
Thank
very
you.
fresh. Thank you, Sarah.
You're welcome.
Thank you. And don't be discouraged. This is new. This is fresh for you, so look at all the products and all the things that Amy's telling us about. I mean, you've got a lot of stuff to try,
Yeah.
a
And
year
there
from
was a really nice guy. I live in Connecticut, and this guy had established a local ostomy foundation. And somehow the visiting nurses knew about him, and they sent him to me. And he's been so helpful. He brought samples, and just somebody to talk with. I highly recommend either a support group or a mentor for people who are going to go through this. It made a huge difference.
Awesome. Awesome. So Sharon, you're very, very fresh. Do you have any questions?
I don't think I have any questions. I think I'm still like in the process of figuring out my products. I started from the hospital with the Hollister 2-piece, and originally, because my dexterity is not fully there, we thought I would switch and stay with a 1-piece. But, and I apologize, my 3-year-old's home, so if you hear a little voice in the background. But I did really well for the first week with my 2-piece Hollister. I was able to actually snap it all the way around. So I was really proud of myself. But today because we got the samples, I met with a great nurse in the hospital who is like all about ostomy. And so I did get samples. And so this morning we switched to Convatec, right, Mom? Yeah, 1-piece. And I'm not quite sure. I think we're having a hard time because I am an oval with the measuring, and the size obviously has changed from when I was first in the hospital. Sorry. And so, yeah, I'm a little nervous that we might have some leakage today. So after this, I will be going to look and change it and stuff. So, I'm just curious, like that oval I'm going to stay in oval, I'm assuming, right? Because I'm not going to probably protrude anymore or come out or get any smaller.
Probably not. It's usually ovals. I mean, ovals are really common. I will say that I don't know if you've looked at it, but Convatec has both 1 and 2 pieces in multiple instead of cut to fit. Where I've had some folks with oval stomas they like that because you don't have to try to cut it to that oval shape. You kind of mold it open with your finger.
Yeah, I saw that when I was on their site and I was reading. I was like, oh wow, that there's moldable. Everything's happening right now. But I'm not sure if I got that in the sample box. I'm gonna have to look a little bit deeper.
It might be worth trying.
So the size of the stoma can change as it heals.
That's what I was told. Yes.
Yes.
About 8 weeks. Typically, they're always like a lot bigger and swollen. They look angry. Like after surgery, they're like real different. And they look actually the scariest. So it's always kind of hard for people because they see it. I'm like, oh no, this is what I'm stuck with, but it's not going to stay like that.
That's my problem.
They're like.
It's scary.
Probably.
I freaked out when I first saw mine. So.
Yeah. They look
and
rough.
now you saw what it looks like. So.
Yeah, exactly. That is a perfect example. They look rough when they come out of surgery because they got like stitches hanging out of them sometimes, and they're pretty swollen. It's like bruising, and there's like scabs around it. It just looks crazy. But seriously, 8 weeks after surgery, it's going to be shrunk down and healed up and like totally different.
Okay. Elizabeth, you had a question, dear.
Yeah.
How are you?
Hello.
Hi.
I'm fine. Thank you. I just want to ask Amy. Although these ostomies is not commonly done here. In fact, I've been meeting people for almost 3 years now, and I don't think I've met one that has done this thing. And a lot of us are struggling managing this incontinence. Can you please enlighten us even if we don't do ostomies, how can we manage incontinence? Is it can it be done without doing ostomies, please?
Um,
Please, and just enlighten up. And all the links you put out there, I doubt if we contact. I'm here in Africa.
right.
I
That was
doubt
the
if we
context I needed to give
get
you. Yeah.
in touch
She's in
with.
Nigeria. So
Yeah, yeah.
just for context, I'm sorry. So just for context, Elizabeth is in Nigeria. She has a foundation and she deals with a lot of other people who have had spinal cord injuries. And so she's saying that of all of the people that she's seen, including herself, she's never seen an ostomy there. And what might be the best way to then, I guess, manage your bowel routine if you don't have that
Yeah,
option? Is
yeah,
that the question,
yeah.
Elizabeth? Okay.
I think it depends on my experience. You know, there's bowel programs, and I think probably a lot of these folks in here could give you information on that. But it really, a lot of it depends on the individual in my experience. So typically what they will do is they will have you, and it also depends on where your level of injury is how your bowel is going to respond to it. So you may have a bowel that's more flaccid, or meaning it just kind of, or you may have a bowel that's more prone to just not really moving at all. And it's like, you have to do things to make stuff come out. And so, usually like most of my folks that are like quadriplegic level, they're doing a bowel program anywhere from daily to 3 times a week. I wouldn't do it any less than that, but I've had patients that did it 3 times a week and they were okay. But it usually involves a level of an oral medication or a stool softener. Some folks will take like a combination of things. They may take like Colace or Miralax or fiber, any combination of these things to kind of keep the stool soft, but not too soft, because if it's too soft, it's going to come out when you don't want it to. And then from the bottom end, what they will do most of the time is some kind of stimulant, like something to stimulate the bowel to empty. So a lot of folks will use like enemies or suppositories that stimulate the bowel to empty, or they'll do digital stimulation, which is kind of just stick your finger up there and wake things up. Hey, time to do stuff. And so this works okay for some people. Like for some people, I have spinal cord injury patients who've been doing this for years, and they are continent. They don't. I mean, very rarely do they have an issue with it, but they do it like clockwork, and they commit hours of their day, 3 times a week or more, to like, okay, this is when I put in my suppository and I do my digital stimulation and I empty out my bowel completely, and that's my bowel program. But it's really, if you have a flaccid bowel, usually this is like a lower level injury, like thoracic or lower level injuries. They may have to do it more often. They may need to do digital stimulation and kind of disimpaction multiple times throughout the day. They may need to transfer the toilet and kind of feel the rectal vault, feel that there's something in there and get it out. So really, the thing is, but even people who do all these things sometimes and do them perfectly as they were instructed in rehab, it just doesn't work. For some people, they just find that they're having accidents. They find that they're having issues with getting impacted and constipation. And, for those folks, like sometimes the colostomy, or it's just, they don't want to do it anymore. Like a lot of people are just like, hey, I'm tired of doing this. I don't want to do it anymore. And that's completely valid too. So I don't know. It's almost like art, and it's real individualized. That's the best thing I can say. Is it's like, well, the two concepts is you typically have to do something to soften the stool and keep the bowel moving. So I don't know what you have available there, but you're going to want to look into drugs that are going to keep the bowel moving and keep the stool a little bit softer. But you don't want to go overboard and absolutely liquefy it, because that's going to be a problem too. And then from the rectal end, to empty the bowel, most folks do better if they're on kind of a schedule. So it's like, all right, well, every evening we're going to put in a suppository and empty everything out.
I have a question for Elizabeth. So Elizabeth, if you want to share, what have you been trying thus far? And the people that you're referring to that you feel don't have a lot of resources, what have you been trying thus far?
You mean myself?
yourself or the people in, from your foundation? Is it, what
Even
kinds of
me,
supplies do you have?
they, that's why a lot of us don't go out often because of these things. Yes,
But do you have
people just
access to suppositories? Do you have access to enemas? What do you have access to stool softeners?
no, not at all. In fact, I do. The one Amy just explained that that's what I do myself. What that like I use my fingers. I don't. It's like I do it once in a week because
Huh?
I don't.
Sorry.
Yes, yes. That's what how I've been doing it.
I don't
In
think that's
fact,
good once a week, Elizabeth.
yes, once a week ever since. And I don't have problem with it. So that's why it doesn't bother me
Okay.
because I don't have a problem with it.
Well, if the
And
digital stimulation is working for you, hopefully you can.
yes, it's
Oh,
working for me. Yes, it's working for me. For
um,
other people,
it's not
like
working for them, the other people.
I doubt because they do complain a lot that can what if they go out and they started messing that's why they rarely go out because of these things.
But are they taking stool softeners then? Because why would they?
I don't no we don't have access to all those things here.
Okay.
Forgive me, we don't. I
Mm.
mean, and it's kind is just may God help us, sha. That's because I don't, we have a lot to do here, in fact, to catch up with you people, we have a lot to do. That's why I asked, but as she just explained, I will keep telling them maybe we look for stool softener, like you said, maybe it will help because of a lot of them still complain about constipation. Which
Yeah.
I don't, yes, they do complain about constipation.
Well, maybe
Maybe
there's some things you
stool softener will.
Go ahead, Amy.
I'm sorry, I didn't mean to interrupt you.
Go ahead. I think.
I think I said if maybe stool softener will help if we have access to them. I'll be telling them. I'll be telling those people. And the one I do myself, I've been, some people we have different. Some can do it. They will just say they can't use their finger to do these things. They will just be, you know. I think I hope they will listen. I hope because some of them won't listen. What works for me, they said it may not work for them. And I believe them. It may not work for them. That's why I asked that what can they do? And as she just said, explained that we pass it pass it across to those people. And I hope it works for them too.
Well, and there may be some things that they can do, like if you don't have access to medicine, if you don't have access to medicines that soften the stool, not necessarily, or suppositories, there's things that you could try. Like you could try using an enema, like an enema bag to clear out the bowel, instead of a suppository. That's kind of another way of doing it, if they have access to like an enema bag and with the tubing, and you put the tubing kind of into the rectum and you gently let a little water go in there and kind of flush everything out. That's a way to loosen up the constipation and get things moving. And another thing that's not medicine that they could try to soften the stool is just, if
What
you
did
think
you what did you call the bag now?
an
And
enema bag.
Okay.
Enema bag, yep. And another thing too is just dietary stuff. You know, if folks are drinking enough water and putting a lot of fiber in the diet, again, it's not gonna, yeah, it's not necessarily gonna replace what a stool softener or a bowel, you know, what those medications may do, but it certainly might help. So we think like fiber, you know, is going to be stuff that's in fruits and vegetables, and lots of water to make it work. So if you have people that are prone to constipation and they're making sure to drink extra water and to eat a lot of vegetables and fruits, that's going to soften the stool too.
Okay. Okay. Thank you.
Also, not for nothing, but I know that you're very limited on supplies. And an enema essentially is just being able to shoot water up the rectum. If you can get a bottle with an applicator tip of any kind, you know, you can use a douche bottle, you can use anything that won't irritate the anus or the rectum and just flush water in there. You know, if you can't get formal enema bags, I know that might be difficult. But the point is to hydrate from above and then I guess hydrate from below to get the stuff moving, kind of. So that's how you can look at it.
Okay.
I hope that answered your question. And I would love to. It's a shame that I have, you know, we all have a surplus of supplies, certain things that we don't use. I could have bottles of Colace, but you know, I'm scared to send that to another country and then, you know, it doesn't sit well with someone and then I don't want my name on that. But I have one question and then I'll get to you, Tiffany. Speaking of digital stimulations, I do find that when my bowel program isn't working, the digital stimulation helps, but there are some of my aides that are uncomfortable with that. So I imagine that they must make like fake like prosthetic fingers, right? That people can use like to get up there, maybe with a hook on them or something. Do you know anything like that? Or am I inventing this? Do I come on to something here? Like what's going on?
I haven't heard of anything, but I'm
No?
about to Google.
Might be about to invent this, Amy. Come on, let's go.
I had an occupational therapist actually make something for me out of plastic that she heated up and shaped. But I think you have to be really, really careful with stuff like that because I don't know, maybe that's how I perforated my rectum, especially because I couldn't really, because it wasn't my finger, I couldn't feel where it was going exactly. So I think that could be kind of dangerous.
You would want to be careful for sure. I do definitely see some available online. And so I guess it's a thing and it exists, but I agree with you. Want here? I'll put the link here. Oh, I didn't mean to send it directly to you. Sorry, Sarah. Oh no. Oh no. Sorry. Why does it keep picking people for me to send okay, everyone. I see something like this online. I don't know. Here's another one. That you would hope the tip's like kind of soft.
Oh my. Yeah.
This one looks like the tip's probably soft, like silicone. A lot of these rehab stores, like Rehab Mart online, they have like they have cool stuff like that. Let's see.
I'm making sure that I'm grabbing all of these, you guys, so it'll all be sent in an email. Yeah, that looks, yeah.
It might be wild. I don't know. Like again, I don't have any direct experience with it, so I don't know. You know, I would hope that it's safe. But oh look, Rehab Mart. Cool, Rehab Mart. They always have cool stuff. So I'll send this link. I like this one because it has like wow, they have a lot. Yeah, so here I'll send you this link. This is kind of cool. This is like a whole bunch of different like toileting aids and extensions and things that can help you do it by yourself better. So I'll just send you that.
Can I say something totally crazy, but everyone here that knows me knows that that's not unusual? Just bear with me here. You know, they make a lot of like dildos and like butt plugs and vibrating butt plugs. Like, have you Tiffany's dying. Have you like what do you think about a little, vibration up there, maybe stimulating things?
Who knows?
Okay.
I have never tried it on somebody, but I don't know. Like I think creativity has its place in all of this because people figure out things all the time.
Okay. Well, then I'll report back.
Yeah, report back.
All right, Tiffany, go ahead. You're up.
Oh, my cheeks hurt. This is why I love this group. So my question is more along the urostomy route because I'm thinking of getting one done. So I'm just wondering, in general, if you would have time to maybe talk to me on the phone about just questions I should ask a surgeon that I'm meeting with.
You're getting a urostomy done for bladder management or for
Well, I'm thinking about it because I have what most people, what do you call yours, Natalia?
What are we talking about?
For bladder?
Mitronoff.
Mine's called a Coke pouch because I've had it since like 91.
Sure.
But mine ruptured.
Okay.
And so they made it smaller. And so I was having a really hard time managing the Coke pouch, and I was still having accidents. So we were putting a catheter in, and now I've become really dependent on the catheter, and it's indwelling, and it's not long term good for me because my bladder neck is stretched. And so I'm meeting with a surgeon in December to talk about a urostomy because I already have the Coke pouch. It's just a matter of can he resection it?
Right. Yeah. I mean, I have met, I have run across folks that had something similar where they've had their, their neobladder, their continent diversion is no longer functional for whatever reason, and have had to convert to urostomy. But yeah, I mean, is it you're talking with a urologist, right?
Yes.
Okay.
Yeah.
Yeah.
And I looked up, I did the link that you did for finding a ostomy nurse, and there's quite a few of them with UC Davis.
Oh, cool.
So it's a teaching hospital, so that's really great. That and for me, mine is kind of under my belly, so it would be, can you resection it to make it higher?
Probably.
Okay.
There's only a certain ask about that, ask, hey, like, what are my, because you've already had a surgery and things have been moved around, that may change like how much leeway they have with where they're going to place it, but ask,
right.
Where can we place this? Can we place this like higher up so I can actually see it and take care of it, that kind of thing. And they may be able to do that. Yeah, but I would definitely have that conversation before you do it.
Yeah, the doctor that I was originally supposed to meet with retired all of a sudden, so that was like, okay, great. So I'm meeting with somebody new, and the only hesitation that the original doctor had is that I have a history with obstructed bowels, and so he wanted to do a CAT scan, MRI.
Yeah.
Yeah.
That seems wise to see what's going, because you've had surgeries in there. I would want to know what's going on before you get on the table.
Okay.
For sure. Yeah. And urostomy, the one thing just to know about urostomy is there's no like on off switch with it. It's going to be a stoma that's constantly has urine coming out of it.
Right.
So there's no you would wear a urostomy pouch, which just has a little spout at the end, and a lot of folks, what they'll do is they'll connect the end of the urostomy pouch to a bedside drainage bag when they're not out, because it has much larger capacity and they can just have that bedside drainage bag collect the urine.
Okay.
Yeah.
Awesome.
But I'm happy to answer any questions if you want to talk about it.
Cool.
Do you have my email? Do you have my email, or do you want to call me?
Yes. I would like your email. That would be great.
What's your name? I'm sorry.
Tiffany Poland. I'm the one
Okay.
in the middle, in the back.
Okay, cool. I'm gonna send you my email, okay?
Thank you. This is really informative.
Yeah, like
Like
overwhelming.
super informative.
Yeah, and I think I've learned that I have to find a different surgeon because she told me flat out that I don't have the option of the irrigation, like you said.
Yeah,
I guess because she was doing it the way she did with the slit as opposed to
which is the laparoscopic way. So one thing to consider, that's like gonna be the minimally
uh
invasive, you know what I mean? And but I think I feel like I've had patients who've had a Hartman's pouch done laparoscopically as well. So let me check something.
that would make getting gut open again as opposed to the lap.
Exactly. Let's see.
Yeah. And that's my biggest fear about my gallbladder is if I ever have my gallbladder go out, they have to do it the old-fashioned way. Yay!
They can do it laparoscopically. So either procedure can be laparoscopic, which there's definitely some benefits to not being cut open like that, you know. It is, you saw the pictures. You could see why a reversal might be a little more complicated with a Hartman pouch. But they do that. Like I've had surgeons that only did Hartman's pouch. That's the procedure they knew how to do, and that's what they did. So it's not an uncommon procedure. It would definitely be the procedure of choice if you wanted to irrigate. But I would, having a good, she may have a reason. I mean, I would talk to her, like if she's a reasonable person, which most people are, like, hey, here's the deal. I really want to irrigate. Is there a reason that you can think of that you don't want to do the Hartman pouch style? Or end colostomy. It just means end colostomy. The end comes out, and she may have a reason, which would be valid to hear, but then you can still go get a second opinion, see what somebody else says.
She was probably thinking because of the way because of it being with the slit that I would still maybe have leakage from below. Maybe that's why.
I think that, it doesn't work well. I've tried, I had a patient that had the same kind who had the loop colostomy and really, really wanted to irrigate, like was just set up. I was like, okay, let's try it. It's not going to hurt, it's not going to hurt anything. And that's the problem they had. The water was coming out the anus. They eventually, like, they did it a little bit and then it just wasn't worth it. It wasn't as effective as it could have been. So they just stopped doing it.
Well, I'll talk to her, but I'm assuming that's probably why.
That's probably why. But maybe if she knows that irrigation is really important to you, she could do an end colostomy instead.
Okay. And on one of the links or resources that you gave us, do they have oh my God, like doctors? Do they have like resources for doctors that do these surgeries like in your area? No.
I don't have that. I don't have anything. The thing is, most surgeons will do these. Whether they all should be doing that. No, I'm just kidding. Most surgeons
Like
will do
any surgeon?
any surgeon. Almost any surgeon that goes into the abdomen. So every general surgeon out there and every colorectal surgeon out there, it's part of their deal is doing colostomies. But what you don't want is like to get your colostomy done in a rural area where the guy does them every 7 years or something, and maybe like has only done 2. It's not that your life's going to be in danger, but maybe the stoma is just not going to turn out great, or they're going to put it in a stupid place. That's what I see. Just being straight up with you. If you go to like a major hospital where they have general surgeons and colorectal surgeons, they're probably doing multiple a week of these because it's not uncommon, and that's who you want to go to. You want to go to a big city and a big hospital with established like colorectal surgeons, which sounds like what you're doing.
Yeah, trying.
Also, it's helpful to know their staff a little bit, like to find out if they're ostomy nurses, how long they've been there and are they experienced? Because in my experience, the nurses were huge. They were just so important. Yes, it was very important that the surgeon did a good job. But those nurses, those ostomy nurses are worth their weight in gold. And if the doctor doesn't have good ones on hand, then that could be a disadvantage.
ask the ostomy nurses. I mean, I would, I don't know. It depends on the ostomy nurse, but you could always, because ostomy nurses in the hospital system are seeing every single stoma that comes out of that operating room, right? And so they know, I know what surgeons make nice stomas. And so I feel like in my area or whatever, you know, and so I feel like if you talked to the, like what, as she suggested, if you talk to the ostomy nurses and you could just say something like, because no one's going to want to throw somebody under the bus, you know, but you could say like, if you were going to get a colostomy, what surgeon would you have do your surgery? And they'll tell you. I would tell people, you know, some people are just, you know, it's nice to have recommendations.
Excuse me. You guys hear me?
Yes, we can.
Mike, I'm gonna have to split. It's very informative, but how does this guy go about watching the recording? As soon as I had to miss, my computer shut off. So
Say it.
how can I go about watching the recording of this?
Oh, can you put your email in the chat?
Where do I put it?
In the chat, or I can just take it if that's not easy for you.
I'm pretty new to Zoom, so I'm
All
not
right, so
sure.
give it to me. I'll write it right now. Go ahead.
Okay, you ready?
Yep.
KUHL.
KHL
No, KUHL.
KUHL
Mike
Mike.
at Gmail.
Got you. So I'm gonna add you to the mailing list, and when this is up on our YouTube page, you're gonna get an email.
Way cool.
Cool. And yeah, we're just about at 4 o'clock. So if there's not any more questions.
I have to get off too, unfortunately. But if you
I
guys
have,
do have
sorry.
questions, John, I'm happy to shoot your resources or give you my 2 cents. And you know, a lot of this is just my opinion from my own experience. So do your own research and talk to other ostomy nurses too.
I mean, but your experience and your opinion is fantastic, Amy.
Thank you.
No
So
doubt.
much. I appreciate your honesty. I appreciate all the resources. I appreciate you being gracious enough to connect with every person that wants to personally and help them out. That's truly, truly appreciated. I know it is. And
Yeah.
so thank you.
And for everybody I said I would call, I have to go pick up my kids from school and stuff. So it might be like a little bit later. I hope that's okay.
It's fine.
Lily, thank you for show and tell. It's beautiful. I could just kiss it. Everyone, have a great week. I'll see all you ladies Wednesday.
Yes.
Yeah. Okay, and everyone have a great week. This has been wonderful.
Bye. Nice to see you.
Bye.
So much. Thank you.
Bye.
Way cool. Bye.